Good afternoon. Good afternoon, everyone.
Afternoon.
Dr. Alfred, take it away.
Hello, Dr. Konya, are you in?
Yes, I'm in.
Okay, yeah, I can see it's 2:04. Yes.
Huh?
Yeah, I'm saying it's already 2:04. Maybe we give them some 3 minutes at small joint, just 3 minutes, then we start.
You can hear me?
Yes, I can.
Okay.
Na wapatia watu dakika mbili wa join wale wana join.
Okay.
Once you are done, then we can put on screenshot. Okay, Dr. Konya, you are good to go?
So you're okay with the people?
Yes.
Yes, I am.
Okay, yeah. Good afternoon, everybody. I would like to thank each and every one of you for attending today's webinar. Today is a continuation of the gynecological cancers. We've already done sessions on cancer of the cervix, cancer of the vulva, and the cancer of the uterus. So today we are going to have a discussion on cancers of the ovaries. And to take us through the discussion is one of our colleagues, Dr. Walter Konya, will take us through the talk. Dr. Konya is an obstetrician gynecologist and also a gynecological oncologist. He's based at the Medat Gynecology and Cancer Center, which is based at 40 Suites, Hospital Road, number 303. So he's an experienced colleague, and I would like to welcome him to carry on with today's discussion. Dr. Konya, you're most welcome.
So thank you, Dr. Mukomba, for the introduction. And I welcome everybody for this webinar. As was mentioned, today we are tackling the topic of ovarian cancer, which, as we know, is a growing problem in our setup. Of course, traditionally, we've been told it was common in the West, but we're also increasingly seeing more and more cases of ovarian cancer within our setup. So just by outline, I would propose we'll talk a little bit about the introduction, do some epidemiology, look at risk factors for ovarian cancer, some protective factors, look at classification, diagnostic approach, and look at management and follow-up. So I welcome you all. As I said, by way of introduction, for many years, ovarian cancer was considered to be a single disease, but it's becoming more and more clear that biologically it is not. It has many different subtypes that have distinctive risk factors. And so these subtypes also influence behavior, both biological and clinical, and also influence the treatment outcomes and the response. We also know that for good outcomes, early diagnosis is important, and yet, especially in our setup, early diagnosis is frequently difficult. And this is because, of course, the presentation is very vague, like we will see. And there are also no good screening modalities, which then means the patients present late, and hence the reason why the outcomes are not as good as we would otherwise want them to be.
You
now,
can screen share them.
Say what?
You can screen share at UoN.
Oh, you're not seeing the screen?
No.
Yeah, that is, sorry about that. Let me just go back. I think something happened because I had shared this.
It's there now.
You have it? You have it
Yeah,
now?
we have it. Yeah, we have it. Thank you.
All right. So in terms of the, you can hear me? Hello?
Yes, we can hear you.
Okay. So worldwide, when looking at ovarian cancer, it is the 6th most common cancer in women, affecting roughly 1 in 70 women within the lifetime. And of course, statistics have shown that it's commoner in the North America, North Europe, and Scandinavian countries. In the US, it is the 2nd most common cancer, and it's responsible for the 5th cause of cancer deaths in the US. Statistics in our region, particularly in Africa, although not very good, but generally we have low rates than what is observed elsewhere in Africa and even in East Africa generally. At KNH, a study that was done by Dr. Cheselem showed that we had among the gynec cancers, it accounted for about 20 to 25% of the cancers that we were seeing. Now I'm having a bit of a challenge advancing my slides. So when looking at, this is just a bar chart to show you roughly what we've said in the other slide. Again, from up there, when you look at North Europe and Western Europe, and you compare it with African countries, you can see that African countries have low rates. Now, in terms of classification, this is just a diagram to sort of illustrate the origin of ovarian tumors, because the classification is based on the cell of origin. Now, if you look at our ovary, it has an outer cover, which is the epithelium. Are you able to see my pointer?
We can see them. We can see. Proceed.
Okay. So this is the outer covering, which is, so the tumors that arise from this covering are the ones we call the surface epithelial, the epithelial tumors. They arise from the surface epithelial cells. Now, within the ovary, we have cells that produce the ova. These ones give rise to the germ cell tumors. And then holding the ovary together and the ova, we have these cells that form the supporting matrix, the supporting structure. They give rise to sex-cord stromal cell tumors. And then, of course, every now and then you will have patients who have secondary metastases. For example, the one shown here is from the breast that then goes into metastases to the ovary, and these would be the secondary tumors. So in terms of the classification, we have these 4 broad tumor types that we need to be aware of. Of course, if you look at the proportions, if you are looking at ovarian tumors in general, almost 3/4 would be due to surface epithelia, and 15 to 20% would be germ cell. And then we have the sex cord cell tumors representing about 5 to 10%, and 5% would be metastatic. But if you look at them in terms of the cancerous ones, the malignant ones, which will be the subject of our discussion today, almost 90% of malignant ovarian tumors arise from the epithelium. So this becomes a very, very important area. And I've given examples of surface epithelial tumors, like the serous tumor, mucinous tumor, endometrioid tumor. The germ cell tumors, for example, are the teratomas that we may have come across maybe in theater or in histology. And the sex cord stromal tumors are like the fibromas and the granulosa cell tumors, which again, sometimes when you see histologies, you may come across. The common areas for metastases usually would be the breast, the lungs, the colon, and sometimes from other sites. Again, looking at the study that was done by Chesarem, looking at ovarian tumors in general, even in Kenyatta National Hospital, about 86.2% are epithelial. So epithelial tumors are quite a significant type that we need to be aware about. Now, I would just like to touch briefly on some of the commoner subtypes, and then we will narrow down to the epithelial, which we'll discuss more in details. We may all have come across tumors called teratomas, which are divided into mature, immature, and there's a particular type called the struma ovary that occur. The typical thing about the teratomas is that you come across a tumor. When you open it, you find it has hair, sometimes it has teeth. This is what is typical about it, common in young people. The struma ovary, what is typical about it is that it contains thyroid tissue, and so a patient may present with thyrotoxicosis. And of course, the management for this kind of tumor usually is surgical. The sex cord stromal tumors, on the other hand, what is characteristic about them is that they produce hormones, usually the estrogens, progesterones, and testosterone. And one of the ones that we know about is ovarian fibroma. Remember, the sex cord stromal tumors, we said, arise from the supporting structures. The fibroma is associated with something we call mixed syndrome, where you have a tumor, you have ascites, and you also have pleural effusion. That is a typical presentation. Now, the granulosa cell tumor, on the other hand, we have two types. We have the adult type and the juvenile type. Because these tumors produce hormones, patients tend to present early. For example, in a prepubertal child, they may come with precocious puberty, and that is what alarms the mother, brings them over for review. You find a very young 6-year-old, 8-year-old already menstruating and has breast tissue. And so the mothers tend to bring them early. In the reproductive age patients, the commoner thing is for them to have menstrual irregularities. And in the postmenopausal women, commonly what you will end up with is postmenopausal bleeding. Remember, because they are producing estrogen, some of these patients may have endometrial hyperplasia, and sometimes they have endometrial cancer from stimulation by the estrogen. Now, we mentioned that the biggest proportion of ovarian tumors would be epithelial, and we mentioned the subtypes, the 5 subtypes: the serous tumor, the mucinous tumor, the endometrioid tumor, clear cell tumor, and the undifferentiated tumor. Now, when I say the word tumor, of course, a tumor can either be benign, borderline, or malignant. And so for the rest of the discussion, we'll look at the malignant epithelial ovarian tumors, which is then what we refer to as epithelial ovarian cancer. Again, 80% of ovarian cancers are epithelial, like we said. The serous cancers are the most common, probably 3/4 of them. And they are divided into high-grade and low-grade types. The mucinous ones account for about 10 to 20%, like we mentioned earlier. What is of significant about this is that they can grow quite large, and they're associated with something we call pseudomyxoma peritonei. This is where you open, you find a tumor, which usually will have ruptured, and the patient has a lot of mucin material in the abdomen. So when you see this characteristically with an ovarian tumor, it will be a mucinous tumor. The endometrioid tumor, it makes up about 20%. And for these ones, you need to look out for endometrial cancer because they're associated in about 10%. And then the clear cell often are bilateral. And then finally, we have the undifferentiated. So probably one would ask, what is the carcinogenesis of ovarian tumors? And this is not well known, but there are several theories that have been postulated. One of them is incessant ovulation, meaning uninterrupted ovulation. Because as a lady ovulates, there is injury to the epithelium, and sometimes you end up with invagination and inclusion cysts of the epithelium. And that recurrent process, in the process of healing and all that, sometimes you end up with mutations, and you end up with cancer arising from those sites. Some patients have the second type, which is a genetic predisposition. And as we continue, we'll look at the sort of genetic events that can lead to this. And then, of course, there's the theory of retrograde menstruation, where carcinogens come in probably through the vagina, come up through the cervix, into the endometrial cavity, and are pushed into the fallopian tube due to that process of retrograde menstruation. Endometriosis, like we said, as the patients get endometriosis, there's a lot of inflammation, and that process of increased inflammation, sometimes things go wrong, and you end up with carcinogenesis. And then, of course, the other theory that is thought is due to persistently high exposure to gonadotropins, meaning FSH and LH. It would be difficult to go into details of some of these theories in the limited time that we have. Now, let's look a little bit about the risk factors, and several again have been postulated. What is known is that ovarian cancer, and here I'm specifically referring to epithelial ovarian cancer, is a disease of older women. 66% occur in women over 50, and probably only about 5% have been observed in women less than 30 years. The other risk factor is reproductive history. It's associated with low fertility, low parity. And also it's been observed in people who delay delivery, getting children until much later in life. We know nowadays, because of issues of schooling and education and career, we are having ladies having their first children even in their 40s. And so for all that time, they've been ovulating. And remember the first theory we mentioned, it means they've had incessant ovulation, which can predispose to ovarian cancer. And then early menarche, again, ladies who get menarche very early will have a long time ovulating before they start conceiving. And then late menopause, again, it means this lady has been ovulating for many years before menopause finally sets in. I mentioned the issue of endometriosis because of inflammation and the process of healing and repair. The other thing that has been observed is obesity and being overweight, particularly with a BMI of over 30. As we know, there's some peripheral conversion and formation of estrogen within adipose tissue, and this could be the reason for that. Hormone replacement therapy, again, these are patients who are being predisposed to extra amounts of estrogen, and so they are likely to be at high risk for ovarian cancer. And then there are other possible risk factors that have been mentioned in literature. Some of them, they are not very well proven, like dietary factors and the old talcum powder that was also mentioned in some of the books that you may have come across. Now, I mentioned the issue of inheritance as a risk factor, and this has been observed in about 5 to 10% of patients. The reason for this is mutation in genes, and usually it's genes that are involved in cell division, cell growth, and DNA repair. And so these patients, typically from the history, you'll find that they have a strong history in the family of either ovarian cancer or breast cancer or colon cancer. You know, they'll tell you, my mother had breast cancer, my sister has colon cancer, my grandmother had another type of cancer. So that suggests a possibility of an inherited risk factor. And so for these patients, the cases of ovarian cancer are much higher than what is observed in the general population. There are some particular genes that have been identified to be associated with this. One of them is a BRCA1 and BRCA2 genes. Remember what we said is that some of these genes are involved in cell division and DNA repair, so that things don't go the right way that they should, and you end up with mutations in the DNA that is formed. Another condition is what is called hereditary non-polyposis colon cancer, HNPCC, also called Lynch 2, where you have colon cancer associated with ovarian cancer. And then there's also other types of mutations, like an ARIDI, more commonly associated with the endometrioid type of ovarian cancer that we mentioned. Now, it has also been noted that there's a particular ethnic group of Jews. They are called the Ashkenazi Jews, who also ovarian cancer tends to be quite common within that population. So that if you are comparing in terms of the risk, patients who don't seem to have any inherited risk have a lifetime risk of about 1.5%. But by the time you're having one first-degree relative with cancer, then an individual has a 5% risk. By the time they are 2, it is 7%. But when you have BRCA1 and BRCA2 germ mutation, then the risk really jumps up to about 35 to 65%. So it's very highly associated with the formation of development of ovarian cancer. So do we also have any protective factors? Yes, there are a few that have been identified that would protect you against ovarian cancer. One of them, again, is related to the reproductive history that we saw. People who have at least one full-term pregnancy, research has shown have a lower risk, and even breastfeeding in itself seems to lower the risk. So these are good practices. It's another reason to encourage breastfeeding to our mothers. In terms of contraceptives, people who use oral contraceptives have been known to be protected, and tubal ligation as well is a protective factor. And of course, coupled with this, generally a healthy lifestyle, feeding well, staying active, maintaining an ideal weight, also become protective. I mentioned that one of the challenges we've had with ovarian cancer is the fact that patients present late. And the two reasons why they present late, number one, we said, is there's no good screening method. But the other reason is that the symptoms of ovarian cancer are very vague and non-specific. So you'll have patients who've been treated for a long, long time for typhoid and malaria and acidity and irritable bowel, who eventually are found to have ovarian cancer. But if you have a patient who has vague symptoms but are persistent and tend to get worse with time, it is important to suspect and rule out such conditions as ovarian cancer. Of course, in the early stages, most of these patients are asymptomatic, but the ones who are symptomatic will present with things like bloating, abdominal discomfort, poor appetite, changes in bowel habits, things like diarrhea, and of course, even changes in menstrual periods, weight loss. And as these symptoms, as the cancer spreads to other areas, for example, the chest, then you will end up with symptoms related to that area. For example, dyspnea, difficulty in breathing, chest pain, and other similar symptoms. The study we mentioned in KNH also confirmed that most patients present very late, and some of the common presentations were abdominal swelling, ascites, abdominal pelvic mass, and postmenopausal bleeding. So then it means, in terms of diagnosis, one really requires a high index of suspicion. By taking good history to elicit the symptoms, and in the history, of course, it is also very important that you do interviews related to, other family members. Do they have cancer in the family? Like we've said, some of these conditions are inherited. And then, of course, a good examination, taking care of all the systems. And in terms of investigations, we have the routine tests, but we also need to do some tumor markers that are suggestive. Of course, some of these tumor markers are non-specific, but at least they give us an idea of where to place the diagnosis, particularly things like CA125, alpha-fetoprotein, the carcinoembryonic antigen. And then on top of this, we also need to do imaging. Now, I know a lot of patients are referred from the periphery, where maybe the only imaging modality available is ultrasonography. Where it is available, please do it. But it is better to ask for a transvaginal scan that tends to have it tends to show the features of ovarian cancer better. Where available, we need to do a CT scan. And if you're suspecting ovarian cancer, then you need to do a chest CT scan. If not, then at least do a chest X-ray. But if available, do a chest CT scan, do an abdominal CT scan, and a pelvic CT scan. And then we have MRI. where MRI is available, it is superior in terms of the imaging of the pelvis. It is superior to the CT scan of the pelvis. So a patient who is able to do an MRI of the pelvis, please request for that rather than the CT of the pelvis, so that you do MRI of the pelvis and then you can do a chest CT and a CT of the abdomen. And then, of course, which is currently also available in the country, one can also do a PET scan. But a PET scan is better off for, number one, picking out metastases to other areas, like the brain and the chest and other areas, and for follow-up rather than for making a diagnosis. There's room for laparoscopy. Laparoscopy is where you put an instrument in the abdomen, and you probably can also take a biopsy. But one needs to be cautious because it is easy to, for example, if you have an ovarian mass and at laparoscopy it is punctured, then you will have upstaged that patient. Or sometimes when the track where the laparoscope went through, sometimes you have, if it was a CA ovary, you have the tumor growing within the track, which may worsen the outcome of the patient. And ultimately, one must do a biopsy and send it for histology, because you cannot diagnose ovarian cancer without histology. I know sometimes we do imaging and you'll find a report that actually suggests the histological type even, but ultimately what you need is an actual biopsy and histology to be able to give you the diagnosis and even the subtype. Like we've seen, ovarian tumors and ovarian cancer have different subtypes that one would need to target the particular treatment. Now, I put in this slide because I realize we have a lot of our colleagues who work in the periphery. There's something called risk of malignancy index. This is something that just gives you an idea that, yes, this patient I'm attending to has an ovarian tumor, but is it malignant or not? And so the risk of malignancy index looks at the ultrasound score, looks at the menopausal status of the patient, and looks at the CA 125 levels that you'll have gotten from the lab. Now, in terms of the ultrasound, there are telltale features that suggest to you that this patient might be having possibility of a malignancy. If you have an ultrasound that talks of a multilocular cyst, or the presence of solid areas within the cyst, or bilateral tumors, or presence of ascites, or actual evidence of metastasis, then these features suggest to you that it's quite likely that this patient has a malignancy. And patients like this, I would suggest that they are referred to a specialist, here meaning a gynaecologist, rather than opening them up and then having to refer them later. It helps a patient to have all this required surgery done from the onset, like we will see later when we are looking at survival and the surgery, rather than opening and closing and referring, or opening, taking a biopsy and referring. One can sort of use these features to decide, do I open this patient in the periphery, or do I just send right away? And so when you're scoring, in terms of the ultrasound score, you look at features. Is there an abnormality or not? Is it one abnormality? Is it two or more abnormalities? And you give it a score. And then the menopausal status of the patient, again, is given a score. And then finally, you multiply that by the CA125. And if the score is more than 200, again, that patient is at high risk of malignancy. And like we said, it may be better to refer that patient to a gynae oncologist who is trained in the kind of surgery that would actually be required for a good outcome. So that is the reason I put this slide here. It may look a little complicated, but sort of just to give us a guide so that as we come across the patients, we are able to make a decision whether should I open or should I refer this patient upwards. Now, of course, like all tumors, ovarian cancers are also staged. I don't want us to go into a lot of details, but it's enough to know that when you're dealing with a stage 1 tumor, the tumor is either in one or both ovaries, but it is confined to the ovaries. And then there's a 1A, 1B, 1C. When you're dealing with a stage 2 tumor, this tumor is spread, but it's within the pelvis, so that the spread is within the pelvis. And again, we have a 2A, 2B, 2C. Every time you see a C, it means the capsule is ruptured and there may be ascites within the pelvic cavity. And then for stage 3, again, it has spread to the abdominal cavity or the lymph nodes. And stage 4 is where you have distant metastasis. Again, there's A, B, C for these stages, but I think going into those details is beyond the scope of this presentation in 1 hour. Now, when you talk about staging, as far as ovarian cancer is concerned, staging of ovarian cancer is a very, very specific entity. Staging is surgical, meaning it is done in theater at laparotomy when you actually open the patient. So it means from imaging, you may have a rough idea how far this tumor has spread. But for you to get the actual stage, you must open the patient. Usually we open through a midline incision. If there's ascites, you need to take that fluid for cytology. Even where there's no ascites, you must do what we call a peritoneal wash. It means pushing in normal saline into the pelvic cavity, the abdominal cavity, into all the gutters below the diaphragm, and then you collect the fluid and send it. Because you may not be able to tell whether there's microscopic seedling within the abdominal cavity. And then you also examine all the organs systematically, meaning you check all the abdominal and pelvic organs, making sure the surfaces don't have any nodules. And then for most patients, the goal is to do a TAH BSO, meaning you remove the uterus and both ovaries and the omentum. Usually we do what we call an infracolic omentectomy. Beyond that, you must also take samples of the peritoneum from the bladder, the paracolic gutter, the pouch of Douglas, some of the mesentery, and the hemidiaphragms on both sides. And then you do lymph node dissection or sampling. And of course, if there are any other suspicious nodules or adhesions, all those also must be sampled. So, I mean, you agree with me that this is quite extensive. And so before you assign a patient a particular stage, one needs to have gone through all this at surgery. And that, again, just emphasizes the point I made earlier, that if you suspect a patient is likely to have, from your risk of malignancy index or your ultrasound findings, if you suspect this patient is likely to have a malignant ovarian tumor or a cancer, it is better to refer them to a person who is trained to do all this, which is what should be done at a minimum. In fact, studies have shown that about 30% of patients who, when you open thinking it's an early stage tumor, by the time you get back your histology report, having submitted all these samples, will end up being upstaged, so that you assign them a higher stage. Now, looking at management, currently what we are advocating for is a team approach, so that we are forming what are called multidisciplinary teams, involving the gynae oncologist, a medical oncologist, a radiologist, a pathologist, a radiotherapist, surgeons, counselors. So it's a big team managing a patient, because it's realized that the outcomes when you go through an MDT are much better. Of course, the team is the one that discusses and agrees on the best management plan of that particular patient, considering things like the patient's age, their general health, their future reproductive desires, stage of the tumor, histological type, the grade, and of course you also take into consideration a patient's preference, acceptability, and affordability. So looking at this, you end up with what we are now looking at as an individualized management plan. It's not a one-fits-it-all approach like we used to do in the old days. Now you focus on the particular individual and agree on the best way for that patient, for that tumor at that time. But ultimately, surgery is the mainstay of treatment. Whether the patient has an early disease or not, surgery is what is advocated for. And if you look at surgery, the surgical approach, of course, it has many roles. Number one, it helps you with the diagnosis, of course. Like we said, you're able to take a biopsy, which you send for histology. You're able to do a comprehensive staging, which is very, very important and helps you decide on what further management and follow-up the patient requires. And then you do cytoreduction. Cytoreduction means excision of all the tumor so that you reduce it to less than 1 centimeter. Again, if you think about that, it's quite extensive surgery, and so it requires someone who's trained in such surgical skills. Of course, cytoreduction can be primary, where you take in the patient and do the surgery before instituting any other treatment. But it can also be interval, meaning this was a patient you are not able to remove everything, and you give chemo and then go back and take care of the tumor. There's also secondary cytoreduction, which we do for patients who have recurrent disease. And surgery also has a role in palliative care. You know, sometimes these patients develop intestinal obstruction and things like that. And so you need to go in and do a bit of intestinal surgery. And so that is now in a palliative setting. Now, I'd like to say that the first surgery the patient gets is the most important operation. It's a point I cannot overemphasize. If you know this patient has an ovarian cancer, it is better to refer to someone who will take care of the problem from the first operation. Remember that patient is already under anesthesia, so it helps if within that single anesthetic event, you can take care of the patient's problem. And of course, it helps with the overall survival. Remember also that patients who are optimally cytoreduced are more likely to achieve a complete clinical and pathological response. Now, the other mode of treatment that we give these patients is chemotherapy. And in fact, most patients will need chemotherapy in one form or another, at least 95% of them. We tend to use mostly platinum compounds. You may have heard of carboplatin and cisplatin and others, but those two are the commonest. And then the other group of chemo we use is the taxanes, the paclitaxel and docetaxel. So these two groups are the ones that are most commonly used. And there are two settings that we use them. One of them is the neoadjuvant chemo. Neoadjuvant chemo means you give the chemotherapy before surgery, then you operate on the patient, and then you continue with chemotherapy. And there are a few indications for this. Sometimes the status of the patient is not very good to withstand surgery. So you want to give chemo, try and improve her, and then operate and continue with chemo. Sometimes the patient has other medical comorbidities that preclude surgery immediately. So you want, first of all, to take care of those and then take them in for surgery. Or the patient may be having very extensive disease. You don't think you'll be able to do optimum surgery at the upfront. And so you give chemo, and so they typically would give 3 cycles. You combine the taxane and the platinum, you operate, and then give 3 more cycles. The other approach is the adjuvant chemotherapy. In this, we give after surgery so that we are able to kill whatever other tumor cells that may have been left behind. Now, there are patients who you have done optimal cytoreduction, meaning you have reduced the tumor to less than 1 centimeter. So you may just give the taxane and the platinum. You give 6 cycles for 3 weeks. I mean, every 3 weeks for 6 cycles. There are those other ones who you may not have achieved optimal debulking, which means you'll give the same medications or chemo, but on top of that, it is advisable, where possible, to give one of these newer drugs like bevacizumab, which is an angiogenesis inhibitor. It's a drug that stops new blood vessels forming within the tumor. There are other medicines that can be given, and we don't need to go through all this, but just again to make you aware that beyond the 2 that we commonly use, there are others that can be given, particularly in patients who have recurrence of the tumor, or for one reason or another are not able to use the other 2. The other modes of treatment, they are newer, available even in our setup, some of them, but of course out in the West, they are quite used extensively. These are called targeted therapies, like the angiogenesis inhibitor I mentioned, the bevacizumab. In the market, it goes by the brand Avastin. Like I mentioned, this one prevents formation of new blood vessels within the tumor, and that way the tumor is not able to grow or spread. The other group is some drugs you'll hear us talking of PAP inhibitors that block the PAP enzyme, and so the DNA is not able to repair itself. The good thing about PAP inhibitors is that they are oral medications, so they are a little easier to administer. The challenge with these newer drugs is the cost. They are quite expensive. And then, of course, there are other things like immunotherapy that are being experimented with out there. So what these new groups of, what about now?
Carry on.
You can hear me? You can hear me? Hello?
Yes.
You can hear me? So with these newer drugs, Mokomba, am I clear now?
You are clear.
Okay, so with these newer drugs, what we are learning is that patients need to have a molecular profile of each tumor so that then you select what to give for a particular patient so that now the treatment becomes quite individualized. Now, one of the questions that comes up is whether ovarian cancer can be prevented. But the truth is that there's no sure way to prevent ovarian cancer. But we may reduce the risk. And some of the strategies that have been used is salpingo-oophorectomy, meaning removing the ovary and the tube, and particularly for women who are at high risk as a result of family history or those BRCA mutations that we mentioned. The other things that have been tried, the use of the bath, which is known to reduce the risk. But remember, the pill is hormone-based and it also has side effects. So you must weigh the benefits and the risks. But what is of more importance is genetic counseling and testing so that one is able to assess the hereditary risk of the patient. Now, what also needs to be emphasized is that all women should be made aware of risk factors and should be sensitized to changes that might be symptoms of CA ovary. Because when it comes to screening, again, there's no effective way to screen. Remember, unlike, for example, CA of the cervix, where it is known that there is a precursor lesion that can be screened for and treated, with CA ovary, we don't have such a lesion. So some of the things that have been tried is to have women who are particularly at high risk have regular pelvic exams. We mentioned the use of ultrasonography, possibly the transvaginal scans, and other things like monitoring the serum markers, particularly CA125. But what has been found to work even better is combining the use of transvaginal scan and CA125. When it comes to the general population, generally, it's discouraged. You don't want to screen everybody. looking at a survival of only about 30% in the population. So the message should be that we need to, as much as possible, diagnose and manage these tumors early. During the survivorship, there are several things you need to look at in terms of rehabilitation, issues to do with fertility of the patient, the sexual health. They need counseling and support, and also pain management. But remember, most of these patients eventually have intraperitoneal disease progression. So they may end up with things like intestinal obstruction, and which then will need to be taken care of. Now, as we conclude, maybe we just look at now the future. Like I've kept emphasizing and what is being practiced in the West. I'm sure it will be with us here very soon.
Out of time, Dr. Konya. Yeah, please finish.
Yes, this is the second last slide. We need personalized medicine. And of course, there are the newer drugs and things like vaccination that are being used. So I'd like to end it there. These are some of the references if one is interested in reading further. And I thank you very much for listening.
Yeah. Yeah, thank you very much, Dr. Konya. I've seen most people have said you are a very good teacher. So I'm sure some of the bigger teachers are listening and they have a good teacher there. Thank you very much. I can see Professor Wanyoro is in the audience. So it's good to also highlight the positives. So thank you very much.
Thank you.
From somebody that has through very well, and maybe briefly we can tackle some of the few questions. If anybody wants to make any remark, then we go to the Q&A. Like he has said, ovarian cancer now is very common. We are more and more making a diagnosis of the same. I think in our setting is the second commonest to cancer of the cervix, at least those who are referred. Like he said, the major emphasis is the symptoms are non-specific. So if we have a patient, a woman who has persistent dyspeptic symptoms, abdominal pain, bloating, constipation, that is not going away with the usual medications of hyperacidity, always remember it could be the signs of cancer of the ovary, and therefore you do the appropriate investigations, mostly, an abdominal pelvic ultrasound, a thorough abdominal and pelvic examination, and we can be able to pick these conditions quite early. The other important point also is the importance of the ideal proper treatment, especially surgery and chemotherapy, hence the need for referral to somebody, to a specialist, a gynecologist who can be able to do the correct surgery and prescribe the correct chemotherapy and plan further treatment even after that. Any comments? Whoever can raise their hand, but let's go to the Q&A. Somebody is asking, how would tubal ligation protect from ovarian cancer, Dr. Konya?
Yes, thank you for that question. Now, I'll take you back to the carcinogenesis we talked about. Remember, we mentioned that there are some carcinogens that start in the vagina and move up into the cervix, the uterine cavity. And eventually, when you have retrograde menstruation, retrograde means it's going in the opposite direction. So instead of menstrual flow coming down into the cervix, it's actually going towards the tube. All those carcinogens are then pushed to the tube. So it is thought that when you have a bilateral tubal ligation, you disrupt that pathway, meaning then that the carcinogens will not be pushed into the tube and onto the ovarian surface.
Okay,
I hope that is clear.
That's clear. And also we know like the high-grade serous type of ovarian cancer is thought by and large to arise from the tubular epithelium. Joy is asking, does somebody with an ovarian cyst, can that put them at risk for ovarian cancer?
So thank you for that question. We need to know what kind of ovarian cyst the patient has. Remember, these tumors can either be just benign or borderline or malignant. There are those there are those types of cysts that, if not taken care of course, can then predispose you to, or they can transform into malignant cysts. And it becomes very important that every cyst must be well investigated and taken care of. Of course, if you have an ovarian cyst in a postmenopausal woman, for example, then it is safer to believe it is malignant rather than just an innocent cyst.
Okay, and the age for younger women in the reproductive period, there are a lot of functional cysts. So it's a question of what the size is and how is the cyst? Does it have solid and fluid components in it? Somebody is asking whether we do, that is Shivikwa, whether we do genetic testing in Kenya.
So I think it is coming up now. There are genetic centers that are coming up, but what has been happening in the country is that they take samples and send them out. And then we eventually get the results. But I think places like Aga Khan, Nairobi are beginning to go into genetic testing. They have panels for that.
Yeah, so once it is available and it becomes cheaper, then our patients will benefit. But most of the samples are sent abroad. Somebody is asking, for a 6-year-old with precocious puberty, what investigations are required?
Yeah, so thank you for that question. Remember, we said if you have a young child with precocious puberty, then one of the things you need to think about is a sex-cord stromal tumor because of the estrogen component. And so this is a patient, of course, you'll do all your baselines and then make sure you do imaging to find out, is it unilateral, is it bilateral, are there any other areas that are involved? But beyond that, then that patient, if they have an ovarian tumor, would need intervention by actually going in for surgery and doing an oophorectomy. Chances are that you'll do an oophorectomy at that age and then deal with the other ovary later. Because remember, fertility was one of the issues we said we think about as you're managing these patients.
Okay. Somebody is asking a comment on the role of radiotherapy and hormone replacement therapy.
I think I need some clarity. Is it in terms of as a risk factor or is in terms of management? Because we said hormone replacement therapy is a risk factor.
Yeah, yeah, I can try it. Radiotherapy doesn't have much.
You've disappeared.
Big role initially. Radiotherapy in ovarian tumors is in particular types like some of the germ cell tumors like this germinoma, or when there is metastasis to particular areas like the spine, then you radiate those particular areas. But by and large, when the tumor is in the abdomen, then you cannot give radiation to the whole abdomen because of the complications. Yeah, so hormone replacement therapy, maybe it will come after you do bilateral oophorectomy and there is disease resolution then to prevent postmenopausal symptoms, then that can come in. But there's a role for, some of the anti-estrogen products like letrozole, tamoxifen, and the like, as a palliative measure in those who are not responding well to chemotherapy. I think then our last one, because of time, let me see which one you haven't. Modes of management that preserve infertility in women of childbearing age. It's an anonymous sender. Then we can close there. Dr. Konya,
I think I lost you.
Various methods of fertility preservation in women of childbearing age with cancer of the ovary.
Yeah, so thanks for the question. So like we said, these patients, when you're managing them, one has, of course, to discuss with them on the preferred mode. A patient who still wants to preserve their fertility, several things can be done. One of them is cryopreservation of the ova, because the tumor might be such that you still have to remove both ovaries anyway. So you would first harvest some ova, keep them frozen for later use. But the other way of preserving fertility, if you're sure this patient has a very early stage disease, would be to just do a unilateral operation and leave the other ovary. But with the agreement that once she has completed her family size, then you can remove the other ovary and the uterus in the near future.
Okay. So I think it is 3:12. I think we've tackled most of the questions. Some can be sent to the KNH research group, and then we can handle it. Those with serious concerns can get in touch with Dr. Konya or any of us, and we'll be more than glad to handle. Thank you very much for your attendance. I think we end it there. Thank you.
Thank you very much, everybody.